I'm all set. Okay, welcome and thank you for joining us today for the meeting of New York City Health and Hospitals Information Technology Committee. Our meeting is officially called to order. I'd like to note for the record that Karen St. Hilaire is representing Commissioner Gary Jenkins in a voting capacity. Karen, thank you for joining us. In accordance with Section 14 of the bylaws, committee attendance, if any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for the purposes of quorum and voting. Chairperson Jose Pagan has delegated Ms. Sally Hernandez Pinero to be counted for the purpose of quorum and voting at this meeting. Next on the agenda, I'd like a motion to approve the minutes of the Joint Medical and Professional Affairs and Information Technology Committee held on April 11th, 2020. Do I have a second?
Second.
Second. Any member have any questions or concerns? If not, I'm going to poll everyone for their vote. I vote yes.
That's one correction. That was not a joint committee. It was just an information technology committee on April 11th.
Okay, so I'll reread it. I'd like a motion to approve the minutes of the Information Technology Committee held on April 11, 2020. I have my second. Sally?
Yes.
Karen? Do we not have Karen?
No, we can move on. Fineski's on.
Benny?
Yes.
Okay, and I vote yes, so we're approved. Okay, we now have an action item to consider for presentation to the board. Ms. Lisa Hendricks, please read the resolution into the record and proceed with the presentation.
Lisa, you're on mute.
Good morning, everyone. Thank you. Can everyone hear me? Sorry about that.
Yes.
Fantastic. Good morning, everyone. I'm Lisa Hendricks from the Office of Ambulatory Care and Population Health, and I'm here today requesting an increase to our existing Lumion contract, an increase in the NTE to cover an expansion of services. If we can go to the next slide, please. Great. I'm going to provide a little bit of background. In 2018, an RFP was conducted for an automated patient appointment reminder system. Lumion was selected and approved for a 3-year contract through fiscal year 22 with 2 one-year optional extensions through fiscal year 24. The original NTE was based on estimated development and estimated appointment volume for only our primary care and women's health services. As of February 22, all primary care and some specialty clinics were live with Lumion automated patient appointment reminders. And these appointment reminders are sent via text message, automated phone calls, or emails based on the patient preference and Epic. We send our text and email reminders in 14 languages. And patients can respond to confirm or cancel, and these responses are integrated within Epic. Daily reports accessible to the sites are actionable data so that the sites can see their visits and cancellations within the reporting. And we've also been able to use these type of reminders for alerts, for proactive communication in case of need to change to virtual visits or because of natural situations like an impending blizzard or storm. Next slide, please. On this slide, you'll see background of our spend across the X-Access. You'll see as we implement and roll out additional clinics, and on the Y is the spend. This just shows how by adding in additional clinics and additional appointment reminders, the monthly spend increases. And if we can go to the next slide, please. So we're coming to the committee and the board today to request some changes. One, we want to, because of the great work that we've seen and feedback back from our clinics and our patients, we're asking to expand the appointment reminders across all primary care practices to all ambulatory care practices, including our specialties. And our specialty appointments account for over 50% of all of our ambulatory care appointments. And as we know that we've seen missed specialty appointments can lead to delay in care, which can have clinical implications. We've also discovered that there are several departments within health and hospitals that have come to us for additional use cases to use an automated patient communication tool. So today we are seeking an increase to the NTE by $4.7 million, taking the NTE from $3.8 million to $8.5 million. So what does that look like? From the inception of the contract through April of this year, we've spent $2.87 million. With the expansion and continuing of our appointment reminders, we expect to hit the NTE by the end of this calendar year. And then our projected spend going into the next 2 years of 1-year extensions. For 2023, it's $2.8 million. And then through June of 24, when our contract would end, would be $1.9 million. That's how we're accounting for the $4.7 million. To date, the vendor performance has been very satisfactory. Some other healthcare customers that currently use Lumion, the Jewish Board here in New York City, Keck Medical at USC, Kaiser Permanente Colon Cancer Alliance, and the Reliant Medical Group. As we head into our first year of extension, we have negotiated a better pricing structure with Lumion that also allows for not only an additional cost decrease, but volume decreases as our appointment reminders increase. We are also looking to issue a new RFP for an automated patient communication service during the first year of our extension period. So some of the reasons for the program change, expanding to all of our ambulatory care practices. One, it's industry standard that patients receive appointment reminders. Another to improve the patient experience. If a patient is receiving the same type of reminder across any medical visit they have, it will start to encourage a sense of behavior in an organization and a comfortableness with receiving the appointment reminders. It's a cost-effective centralized system. There still are some clinics that are doing appointment reminders themselves or using frontline staff to make calls, so we can see a decrease in that admin time where they can focus more on patient-centric activities. And then we can collapse any of the one-off appointment reminder work into this more cost-effective volume discount. We're also look to see decreasing number of calls to the contact center to verify or cancel appointments, which allow us to take more calls from patients who are looking to make appointments or need assistance. And then we've seen anecdotally and through some of our responses from the clinics and speaking to them, a reduction in their no-show rates, which is helpful. We want to make sure that all appointment slots are filled. And then working with our Epic Growth consultants, they strongly recommend an automated appointment reminder as we improve to drive clinic efficiencies and patient experience. And we'll go to the next slide. Just a couple of testimonials that we have. One from Dr. Vorsinger, who is at Bellevue Cardiology. They've seen a noticeable difference in patient no-show and patients who are unable to show for their appointments, a more effective way of rescheduling. Scott Singer in urology at Bellevue. Also, they've seen a historical no-show rate of 35 to 40%. They've seen a great reduction to 10 to 20% as they're looking at specific weeks in March where their no-show rates were declined. And they've even heard some patient feedback where getting the appointment reminders was very helpful, and it also made canceling or rescheduling their appointment much easier. Talking with some of our administrative staff, Amy Harris out at Elmhurst said that they saw a significant drop in their women's health service no-show rate from 33% to 25%. And also with their rehabilitation and in their physical department, they saw more than a 50% drop of those type of appointments down to 25 to 30%. And we are also able to help Elmhurst successfully reach out to patients during a big snowstorm last January, where we were able to communicate to the patients and let them know that their appointments had to be canceled or changed. Next slide, please. We did a patient satisfactory survey in March, and of the patients that we surveyed, these are folks who received Lumion appointment reminder. We had a 77% response rate to the survey, and 97% of those patients found that the appointment reminder was very helpful. We've also seen, as we look at the ambulatory care no-show rates, we saw a nice almost 50% reduction as we looked at appointments from the July 2019 period through April 2022. Next slide. So in addition to the appointment reminders for our ambulatory care services, we've also rolled out to other use cases. A couple of use cases that are already in production are the mobile insulin titration intervention program, and also the NYC Care membership renewal and quarterly newsletter notifications. Some of the departments that have approached us to launch this service, surgery appointment reminders, also family member caregiver surgery text notification, remote medical device monitoring, and even since putting this presentation together, we've had 3 other departments come to us about using the Lumion services to interact with our patients. Next slide, please. As we look at the MWBE, when the procurement was conducted in 2019, this was prior to the system's adoption of the vendor diversity policy. And so the procurement was assigned a blanket MWBE goal of 30%. If we look at the opportunity and analyze it today, adopting the new policy, the goal would have been set at 3%, with implementation services being the only subcontracted portion of the work. Much of this work is self-performed. A lot of the cost is tied to licenses, maintenances, and the professional services, which include development of their proprietary software. In 2019, Lumion was granted a total waiver based on the following. The software is owned by Lumion. Lumion self-performs all services except for the hosting, and the hosting is done through AWS for all of Lumion's customer. A waiver of circumstances is consistent. It's consistent with the business model exceptions, under the vendor diversity policy, operating policy 100-10. A diversity analysis was completed. 100% gender was reported by all employees. That broke down into about a 50% female to male with the leadership team, and 43% to 57% female to male amongst the employees. 42% across the board of all employees voluntarily reported their race and ethnicity. How we broke that down was 70% of the people in leadership roles reported, 32% of employees self-reported their race and ethnicity. Our vendor performance evaluation, our vendor has performed well to our performance expectations and standards. They've been very receptive and been a great partner to work with. And next slide. And in conclusion, the request to increase the NTE, the original NTE was set to $3.8 million, and that was only to cover primary care and women's health services. we look to expand the appointment reminders to all of ambulatory care services, especially the specialty appointments, as well as the additional use cases that have come to us across the organization. So to break down the total new contract value that we are requesting of $8.5 million, $6.674 million is attributed to the ambulatory care appointment reminders. Of that, about $121,000 was for development services. Most of that development was done in the initial phase of the rollout. We have about $763,000 in additional use cases that are ongoing or set to go into production. The development costs were already spent in setting up those additional use cases. And then based on just the success that we've had and the interest from across the organization, we're anticipating more use cases and more use of Lumion. And so we've estimated an additional $1.1 million in those future cases. As we will near our approved NTE by the end of this calendar year. And so we want to make sure we can continue and reach all of our specialty care appointments. And the increased demand for Lumion's automated patient communication service has been very effective and very efficient to improve the care and patient experience. And that concludes our presentation this morning.
Thank you so much, Lisa. We appreciate it. Kim, would you formally read the resolution into the record?
Yes, Dr. Katz. The resolution authorizing an increase in the funding for the New York City Health and Hospitals Corporation, the system, to contract with Lumion Incorporated, Lumion, for an automated patient appointment reminder service, which was made in early 2020 for a 3-year term with 2 one-year renewal options available to the system from its original funding limit of $3,842,760 to a new not-to-exceed limit of $8,553,000. Thank you, Dr. Katz.
Thank you. And let me poll on my fellow board members for any questions that they have. Sally?
I have a lot of questions. I'm trying to follow it, and I'll start with the numbers questions because I'm a little confused. When Lumion was originally selected, what was the amount for the 3-year period?
The 3-year period plus 2 one-year extensions, the NTE was $3.842 million.
So what was it for the 3 years, and what was it for each 1-year extension?
The total, including the extension, was $3.842 million. And that was just to cover.
Sally wants to separate it. Can you, was the 3.8 just for the 3 years, or did it include, was there a separate amount for the two 1-year extensions?
Yeah, no, my understanding, Dr. Katz and Sally, was the 3.842 was to cover the 3 years plus 2 years, 1-year extension. So total spend of $3.842 million over 5 years.
Okay. It sounds like, Sally, no distinction was made.
Yes, and so we have spent in 3 years, we spent the 3.8 million in 3 years instead of 5 years?
No, look at the slide that she has up now. She has the spends exactly for you.
Right. No, Dr. Katz, but the projected spend through year end is 3.8. That would have been for a 3-year period, right?
Mm-hmm. It would have been. The projected spend, if we are to roll and expand to the specialty services, we will hit our NTE of 3.84 at the end of this year.
Okay, all right.
If we don't expand at all.
Right. Now, your chart, the financial spend data, your chart, for like from July of, I guess it was 2019 to November of, I guess, 2020, it was constant. And then it started escalating. Were
Yes.
those months all ambulatory care patients?
Yes, this is all, the initial was ambulatory care, primary care, and then we started adding the other services, then expanding into women's health, and then we had some additional use cases, and then expanding into some of the specialties when they were rolling out the Gotham site.
Okay, bear with me. I'm going to go a little slower than you are.
Okay, no problem.
Okay. The orange line that goes through represents what?
That is just looking at the cumulative cost.
Okay. So the amounts above and below the line don't indicate the bottom part is ambulatory care. That's just covered by the area underneath that talks about 48 departments, 78 departments, the numbers going up. I'm just curious about if ambulatory care was the 26,000 going across, how many more patients are we reaching out to that our costs go up so sharply?
Yeah, specialty care represents a little more than 50% of our total appointments.
Okay.
So as we add those specialty appointments, we're basically doubling, and even a little bit more than doubling, the amount of appointment reminders that are being sent. And as we roll each clinic, some having more specialties than others, we look at the average number of appointments they have by week as we try to estimate what that cost is going to be based on the number of appointment reminders we send. So as yeah, if that's helpful.
That's very helpful.
Great.
So I'm curious to know, when does the patient make the selection about whether it wants automated or text?
We look at what's in Epic. We look at what's in their Epic chart, and they indicate how they like to be communicated with. Some are calls, some are text, some are email.
Okay.
So we use.
And when you, in your evaluation of effectiveness, did you break down whether people preferred automated text or email, or did you just ask, how did you like being communicated with?
Right. We asked, how did you like being communicated with? And the majority of the patients receive a text communication. And so the survey that we did was via text. We sent the survey, the patient satisfaction survey, via text message.
And just,
the majority.
I'm curious to know, this is your billing by number of contacts? Is that how you get billed?
We're billed by the number of text messages or emails or automated phone calls. I will say, depending on the message, each text message is 160 characters. So depending on the service, one message may be 2 text messages, one message may be 3. So we may be billed, so we're billed by text message, not by total message or by patient.
Oh, that's helpful, because I think it explains some of the sharp incline cost as well.
Right.
I just had one other question. This proactive communication, is that text messages you send, or you contact everyone with an automated message? Or what is proactive communication?
We contact them through the channel of choice, whether it's a text message, an email, or a call, based on what they have in Epic. And then we contact them 2 days before their appointment to remind them of their appointment and to give them the option to reschedule or cancel. So it's a proactive reminder ahead of the appointment.
Okay. All right. Those are all my questions. Thank you. I'm sorry to take so long.
No, sorry, those are good questions.
Thank you.
Vinny, do you have questions?
Yes, I have a couple. Thank you, Dr. Katz, and thank you for leading while I'm in the phone. I appreciate it. I think, Lisa, following up on the question by Sally, do you think it will be possible to present a chart similar to slide 3, showcasing the forecast or the number of departments and the usage for 2023, for the remaining of 2022, 2023, and half of 2024 to correlate with the expenditure that is forecasted during that period?
I think we can. I mean, we look at the facilities who are yet to roll out, and then we look at the average number of appointments per week, and then we base that on the number of messages that we would send to the patient. So some of it is we're extrapolating. As our access to care opens up, our patient appointments will increase, our messages will increase. So we've done our best educated guess to project the future costs of what we look to spend in 23 and through the first 6 months of 24. It's all it's estimated and it's high level, but we have that estimation by facility and department within the facilities.
Thank you. I think it will be helpful because, we are more than doubling the amount for this particular contract. I understand, the services that they're providing, the impact that they have, but I think it would be good to have a clear indication of where that increase is going to go and how big reach will be. So if you can do that for the meeting at the board, I think that will be helpful and that will help answer some of questions like similar to Sally.
Okay, and maybe, since we just rolled out only primary care and women's health, and we know that on average, we're seeing specialty appointments being 50 to 55% of our total appointments. Maybe we can show, our primary care is somewhat consistent until we open up some additional access. We should be able to show the difference because we are doubling, the amount of reminders that we're sending.
Yeah, I think that would be helpful. I think the chart on slide 3 is very helpful. So it's something graphical like that could be helpful. At least it will be very helpful for me.
Okay, thank you.
And my second question is about the MWBE and the analysis that you made in 2019 that showcases that there were a 3% availability, but the vendor received a full waiver. Now for this increase, which again is double of the original amount, did you do any availability? And if so, why didn't we use a goal of the amount of the availability at least?
Well, the majority of our spend is on technology. It's the licenses, it's the maintenance, there's development work. The team did their analysis and found that, the only part of the work that could have been subcontracted out would have been implementation services. This is a small company. All of that work was done in the initial stage as we were preparing and setting up to put the appointment reminders in production. So they don't have anything else that can be subcontracted out. And it's a proprietary software that their developers make changes as we roll, these specialty clinics out or have to make any changes to the messages that are sent out to our patients.
So in that case, I think it would be helpful to put something to that effect on the slide or, because here in the second main bullet, it talks about the 2019 waiver, but in effect, they're also giving a waiver for the increase. And I think this explanation of why we're giving such a full waiver and the analysis that was done, that there were, that our team did, that there is nothing that can be subcontracted. I think it would be good to make it explicit here if possible.
Okay, so maybe adding more detail around the sub-bullets here, that we're analyzing the opportunity today and the goal would be set at 3%.
Well, one thing that's Benny's question shows is a little confusing, Lisa, is where we say with implementation services, a lay person doesn't necessarily know that you mean the development, right?
Gotcha.
So the development is done, right? So so you identified that the development would have been an area where there could have been an MWBE, but the development was done several years ago. Now you're just continuing, more globally, this is a contract we're going to rebid, right? And so we have reason to hope that in the rebid, which we'll be working on shortly, because this is just a one-year extension, that this contractor would either do better or some other contractor would do better on the MWBE.
Yeah, thank you, Dr. Katz. That's very helpful. And my apologies. That's helpful. I want to make sure that we make the additions that will be effective for our next meeting. Thank you.
Yeah, I'm elaborating in what Dr. Katz said. I think the idea is to put here a bullet that says that, in essence, we are giving them a full waiver for this increase. And the rationale is what Dr. Katz mentioned, that the implementation was done. And will make it clear. I also noticed, and the last bullet, I don't think you presented it, but it is in the document that we received, is the corporate social responsibility, the CSR. And I think this is, I appreciate this information being shared. However, it seems to be extremely general, and it would be good if there is some examples or initiatives that they are undertaking in terms of implementing this CSR, just to understand their work on this area. That would be something that I would find it extremely helpful.
Benny, I'm not sure I understand. If Lisa understands, that's okay. What is CSR?
That's the corporate social responsibility. There is a document, a one-pager that they provided in terms of their work to the environment, to the community, and to their workplace. And they mentioned, they mentioned that they have, high standards and that they are committed to prevent pollution, and Lemon runs an environmental awareness training. So it's very general and very high level. If it will go to at least in that document, show some examples of the initiatives that they are actually undertaking.
I see. That makes a lot of sense. Thank you. And I'm sure, Lisa, if you ask them for examples of the things they say, they'll provide them.
Yes, we'll get some more details around initiatives.
Dr. Katz, can I ask one other question?
Please, Sally.
On the initial development costs, how much were the initial development costs?
Initially, for the primary care and women's health, it was a little over $100,000 to get that going. And then some of the additional use cases for the mobile, for the MIGHTY group, that is the mobile insulin titration intervention, that had quite a bit of development itself. And that development was around $100,000 just for that program when we launched that.
Is that literally, I'm trying to figure out what it is they do. Do they input all the patient's names somewhere? What is it they do?
Sure. They're building out the framework of what the appointment reminders are going to look like. They're also setting up a communication path receiving the information from Epic that goes into their system. So then it generates the appointment reminders. They send a cadence of how the appointment reminders are sent, and then they set up reporting. So the facilities can actually go in and see their reports of their patients, who accepted, who canceled, or needed to reschedule. So it's setting up the entire foundation of the messages, the reporting, and communication. Yeah.
Do you think that it's hard to rebid this? Is this like unique enough so they're going to have a certain competitive advantage, or is this something that is like done easily within the industry? And that's my last question, I promise.
Sure. There are other companies that do this type of work. I would say it's probably very similar across the board from a development perspective, because there's just a foundation and a communication pathway that you have to establish. Mm-hmm. One of the things that you look at, about changing vendors is the time of implementation and the time of development, right, and the hours that you put in to make that change. Mm-hmm. But the development, that they're doing is definitely unique to their to their code. But developing and setting up appointment reminders is not unique in this space.
Okay. Thank you so much.
Absolutely.
Okay. Have we done any other questions that board members wish to ask? Okay, then I'm going to poll each member for their vote. Sally?
Yes.
Benny?
Yes.
And I vote yes. Thank you very much. Okay, Kim, we now will have the CIO reports present and an information item provided by you.
Right. So we'll be providing our update. Thank you, Dr. Katz, and members of the committee. I'm Kim Mendez. I'm the CIO for New York City Health and Hospital. I'm joined today with Dr. Michael Boughton, who's our corporate CMIO, and Sean Koenig, who is our Chief Application Officer, Jeff Lutz, our Chief Technology Officer, Shoma, who's our Chief Information Security Officer, and also Biopour Carrier, who is our AVP of Finance. We can go to the next slide, David. Thank you. Just our overall update agenda. We'll focus on 4 key areas today. One around clinical informatics with the utilization of MyChart. Also, we'll ask Dr. Boughton to speak briefly on our new remote radiology program, which has been kicked off, and where we're going in that area. Sean will speak briefly on our clinical application, new areas that we are implementing with Epic modules, as well as our upgrade. We'll do a very brief update on our 2 data centers, our new migration to both QTS and CyrusOne. Jeff was there. And then if we have time at the end, we have 3 quality improvement items I'd like to touch on for our committee. Next slide, please. Just including here our overall 2022 goals for information technology, and all the update areas today align with these goals. Next slide, please. All right, Dr. Boughton, I'll turn over to you briefly here.
Great. Thank you so much, Kim. So what this slide is showing you is how many times a user logs into MyChart per year. Over the past many months in front of this committee, we've talked about what our activation rate is. And in the past year, we've ranged from 70 to 72%. So if we fall outside of the top 10 percentile, I will come back and mention it here, but our activation rates have not only been steady, they've been stellar. We're in the top 10% nationally. So what we're doing is we're shifting our attention to the intensity of use and using this as MyChart as a patient engagement tool. And to that end, I want to share with you some examples of how we're doing that. What happened last week is we went live with a new feature that allows a patient, when they show up to their appointment, to check in If they don't have any paperwork that needs to be signed, they can check in directly from their MyChart account and don't need to go to the front desk. And we've built a workflow around that with our ambulatory colleagues. We're also pushing more and more information to MyChart to make it a better patient engagement tool and more useful to our patients. We're releasing 97% of our labs to MyChart right now, and we're releasing 97% of physician notes, nurse practitioner notes, and we keep expanding the type of notes we're releasing. Just recently, we started releasing our speech language pathology notes. So what we're doing there is we want to organize that information to keep it useful, but really put the patient's electronic chart in front of them and have them have access to it. We can go to the next slide. On the enterprise remote radiology, I'm going to split this up into two buckets here. We have the short-term need where we had a third-party vendor that was doing overnight reads at some of our facilities. We're moving away from that, and we're switching to a model where our radiologists at multiple sites can support and also work from home. In order to do that first step, we needed to get 10 workstations into our radiologists' homes so they could do this work from home. That part is complete, and we've done that successfully. The next part of this is not just to move away from these vendors that were providing services at a few of our facilities, but to move to a true enterprise system where a radiologist at King's could do the reads from Harlem and vice versa, depending on specialty. That's going to take an additional about 60 radiology workstations plus 11 mammogram stations. And that part, there's a dependency on the vendor getting us these workstations, which in the current climate with the international situation with just getting hardware to us, that can be at jeopardy. But as we get these in our facilities, we're going to be rolling them out to our physicians' homes to allow them to better support our system. The other part of this that I really need to mention is an additional 70-ish workstations. That's going to take a lot of support from our team so we can make sure to maintain those at home. And we're in the process of hiring full-time support here so we can help our physicians at home.
Okay, thank you, Dr. Boughton. We'll go briefly to our clinical applications. Sean will do a brief update.
Thanks, Kim. So we've had a couple go-lives that we're very proud of recently. The first was with our Willow ambulatory retail pharmacy module. So this is when we're giving our patients outpatient medications. We went live on May 7th with our pilot sites at Kings and Lincoln. We had a few issues that were all quickly resolved. We received some major praise from Epic as one of their best Willow ambulatory go-lives in recent memory, so we're proud of that. We had at the elbow support continued through June 3rd. And our next go live is scheduled for several sites at August 6th. We're partnering very closely with Dr. Danielle Dabari and her pharmacy operations team on exactly what the rollout schedule is going to look like. We're trying to do a more aggressive rollout schedule to get everyone live faster. Additionally, we brought up MyAM addiction management on the last site, which is King's. So that's for dispensing medications for treating addiction management patients. We were able to provide some new functionality, and also this is replacing a legacy system, AMS, which has some security concerns, so we're happy to be able to move along with that. And finally, look forward to reporting back during our next meeting about the Wisdom Go Live for our dental clinics, which is scheduled for July 1st, with about half of the clinics and then the remaining half of the clinics going live in October of this year as well. Thank you.
Thank you, Sean. Our next slide, David. And Jeff will give a brief update on our current status of our data center migrations.
Sure, thank you, Kim. And yeah, so briefly, we are continue to make very good progress as we make our migrations over to our new data centers, primarily focusing in on the QTS and getting out of the more expensive data center in SunGard in New Jersey. And we are at 50% at the end of May. Including going through the first 6, it says 19 move waves here. We've actually been working and have consolidated down that 19 now to actually 11, 12 move waves. So we continue to make good progress. And that includes over 600 servers that have been migrated, over 200 applications. At the same time, the non-production sides for Ensemble, as well as Epic, have already been migrated. And our right now, Epic is running in a disaster recovery side inside of our SunGard data center, so it's all live out of our Jacoby data center. So the equipment by the end of this month, actually, all of that equipment will have been moved. We've already moved one of them, so we could actually run disaster recovery right now, either out of the new data center or the old data center if need be. So we make good progress with a lot of great support from everyone, and we appreciate it.
Great. And just to keep in mind, this project is a 2-year timeline, so our overall completion for both of the new data center migrations will be completed by May of 2023, and we're 50% complete on both of those. David, we can move forward to the next slide as well, please. Okay. Our final area, thought it would be good. We worked from a continuous quality improvement mindset. I wanted to actually highlight, and we'll just touch on maybe 2 or 3 of the top 10 new features to support our caregivers. This is from an effectiveness of EPIC, our electronic health record. We can, Mike, I'll turn it over to you.
Great.
Let's just do 2 of those.
Yeah, sure.
Okay.
We can go to the next slide. So in collaboration between our EPIC team here and our clinical councils, we make many hundreds of changes a year to our system to optimize it and improve it. You can go to the next slide. So I wanted to go through and attract some of your attention here. So what you're seeing here is we changed the admit order for our system. I just want to give you an example of some of the work that we're doing. So when you change the admit order, this is if I'm in the emergency department admitting somebody to inpatient, these are the screens I would see. And as of a couple months ago, I could admit people with illogical combinations. So I could take a pediatric patient and I could put them in the adult medical intensive care unit. And that would get cleaned up by our admitting office before they went, or on the back end by our financial colleagues. But we were creating a lot of rework in this situation. So what we did is we built in cascading logic, which if you choose a patient class, it only gives you the services like medicine or surgery that are available for that patient class. And then for a level of care, MICU, step down, you only get those levels of care that are available for that service. So we took what was a process that had a lot of rework in it, and we almost eliminated all of that rework. And this has gone very well. Physicians have, it's been a very good process that's cleaned it up for us without really hurting us at all. You can go to the next slide. Virtual Express Care. So there's been a lot of work around Virtual Express Care. They've continued to expand. Part of what they've really been expanding into, as you likely know, is that they've been providing more and more care for our patients that have COVID. So what we've done for them is built what they're called smart sets, which is basically just groups of orders that the physician can easily and quickly pull up. So if you're going to be providing the monoclonal antibody or the oral antiviral, along with ibuprofen, Tylenol, and the discharge instructions and all that kind of information, it gives it to you at one click and really expedites that process. So I think this is just a good example of how we standardize workflow to make sure our patients are getting the right level of care and also simplify it and make it quicker for our physicians. There's another 8 that I will not go through, but I think that's a good example.
Okay, great. Thank you, Michael. And David, we can go a little bit further. Keep going. And one more, please. Additional. I'm sorry. Okay. So the last 2 areas I wanted to highlight from a continuous quality improvement is our management print services initiatives. And Jeff, if I could just go to you for like a minute overview of how our team was really doing a lot of great work in streamlining our carbon footprint.
Yes, so thank you, Kim. And right, so managed print services, to remind everybody, this is aligned with our contract with Canon. Not only do we look at the ability for us to consolidate the number of printers that we have, but we want to make sure that we're creating a more efficient and also secure print environment. And so these are the 4 pillars that that the team looks at, each of these different areas and how they go about addressing it. One is through technology, consolidating. Again, we have secure print, where print anywhere, where they can print with their badges. You go to optimization. How do we better print? Either putting the larger print jobs to printers that are designed for it, or to reduce printing overall. User behavior, provide tips in how we can better and I'll have an example of that here briefly just after that. Sometimes we just print for the sake of printing. How do we become more efficient where we can already save it electronically and reduce that time down? And again, finally, consolidation on a number of levels. And within here, it gives you some of the bullet points of what we look at, and then the blue highlights areas that we would be concentrating on. If we could go to the next slide. So one of the areas you'll hear unprint. So it's their way again for sustainability of reducing carbon footprinting. How do we go about not printing? And they've come up with some creative videos that are both instructional as well as informative to the end users on some of the common tasks that we have of, a lot of people print out emails, for example, and want to keep them. That informing them that we do already preserve emails in a way, if you want to keep it, how you can export it out, leveraging other applications like OneNote and the like. So you'll see more of those types of initiatives as well.
Okay, and then in closing our update to date, the last area that I wanted to mention was utilizing a software and application that we already have and looking at additional functionality that we can leverage in the clinical care environment. And one of those areas is around Everbridge. And just as a reminder, Everbridge is our mass notification application that we use in disaster and emergency management. And the team has been working with a small group, which I would say is really the vanguard of how could we leverage an application module called Care Converge to help drive communication across different cardiac emergency teams, like just a STEMI team or an ECMO team, so that it's real-time communication. One of the other things that we've been able to do is to have if there is someone coming in through an emergency pathway, that we could actually see their EKG. And so the team that's at the hospital preparing to provide the cardiac care for that patient has a preview before the patient actually comes into our facility. So leveraging an existing software that we have to support care for our patients and streamline that level of communication across our care providers has been really well embraced. And so it's just the beginning with this particular team, but we are looking to expand that across our enterprise. So wanted to close on that quality improvement note and turn back over to the chair.
Thank you so much, Kim, for your excellent report. Just let me check with my fellow committee members if they have any questions. Sally, any questions?
No questions, thank you.
Benny, any questions?
No questions, thank you.
Okay, very good. Then let me ask if there's any old business, any new business, and there being no further discussion, all in favor of adjourning this meeting, please say yes.
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 Okay, anyone no? Very good. The meeting is adjourned and we have 5 minutes to spare. So good job,
Yay.
everyone.
Thank you. Bye. Thank you.
Bye-bye, everybody.
This meeting is no longer being recorded.
Okay. Sorry to push you all. Thank you.